generally, when we have a health issue, we look forward to recovering. But then there are times when you realize that something will be with you always. Chronic pain and rheumatologic conditions tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. It's hard to imagine waking up each morning knowing that you'll spend the day in pain. The quest to conquer chronic pain, arthritic problems, things that cause you basically a lot of discomfort is a goal that we've had since the beginning of medicine. First, let's take a look at this week's Prairie Doc quiz question. Pain management should take into consideration A, importance of sleep, B, pharmacological effects are not always effective, C, physical rehabilitation helps bring return to function, D, all of the above. We'll have the answer later on in the program. Well, joining us tonight is Dr. Jennifer May, MD, who is a rheumatologist from Rapid City Medical Center in Rapid City, South Dakota. Thank you for joining us, Jennifer.
My pleasure.
So we're going to talk about rheumatologic issues and the pain that develop from these things. Let's just talk about the field of rheumatology. Really, rheumatology, what is it and why in the heck did you decide to become a rheumatologist?
Well, rheumatology is really a specialty that involves the immune system. So usually the way I explain it is it's when your immune system sort of misbehaves and it starts seeing parts of you like a foreign object or like it would if you had an infection, and it reacts or attacks certain
like
parts of your body.
If you are an infection, your own body is an infection, it says, get out of here, you're killing the body.
Your body always recognizes what isn't you, right? So when your own body attacks itself, it's like stealth, right? Your body doesn't stop it or slow it down, it just lets that reaction take place because it's you, it's your immune system. So you develop symptoms from whatever it is that is being bothered by your own immune system, that autoimmunity, whether it be joint swelling, rashes, inflammation of the kidneys, inflammation of the lungs. Like there can be all kinds of
Swallowing
symptoms.
difficulty.
It can be, yeah. Variety of things.
A variety of things, but mostly we think in rheumatology, we think about joints.
Yes, most commonly people think of rheumatoid arthritis. That's probably the most common inflammatory arthritis that we take care of in rheumatology. And so that is a very specific type of inflammatory arthritis. I mean, there's many, many types of arthritis, not just one.
Let's name the kinds of autoimmune diseases that are out there where your body attacks your body. And I mean, it all started with rheumatic fever, right? What is that?
Well, rheumatic fever is more of an infection that you can develop kind of afterwards, an inflammatory process. So like joint pain, rashes.
It attacks heart valves.
Yes, heart valves.
So
exactly.
And it's all a misinterpretation that strep infection it makes the body think, oh, the heart valve is a strep
right,
infection.
It's like what molecular mimicry, sometimes we'll call it that way, where you've had this infection, your body identifies that infection, that immune system identifies that, maybe that infection clears, but that immune system then misidentifies something very similar in you as that same bug and just keeps on behaving as such.
And destroying sometimes.
Yes.
Destroying the heart valve, for example, in rheumatic disease.
Right.
But rheumatoid, oid meaning like. So rheumatic fever-like disease or rheumatoid arthritis is a different kind of disease, totally from rheumatic fever.
Yeah, totally different. So it's really an inflammation or swelling of the small joints of your hands, wrists, feet, and ankles. It's symmetric. It's signs and symptoms of real inflammatory conditions, particularly joint things, are going to be really profound morning stiffness. Not like you get up,
and you're
take
stiff.
a shower, 15, 20 minutes. It's
an hour.
Yeah,
or
sometimes
more.
Sometimes people say it's all day, but maybe it's okay by noon. You know, I mean, it's a really pretty intense stiffness. Usually
mostly wrists and hands.
Yeah, it's symmetric. It's like I say, if both wrists are involved, it's pretty much rheumatoid.
Arthritis.
Elbows can be involved, but people feel like they're walking on marbles. That'll be kind of a term they'll use. And then you just kind of feel bad. I mean, even though it's the joints that are the primary symptom, there is a systemic inflammation, fatigue. Sometimes people can have really impressive weight loss, like we call that rheumatoid cachexia. You can have what we call extra-articular manifestations, fibrosis of your lungs, vasculitis of the skin. So there's lots of different ways that the disease can present, and we do much better job of treating rheumatoid arthritis in the last 20 years than we did in the past. So with early and aggressive treatment, we don't see as much of those long-term extra-articular outside the joint problems.
And one of the major treatments, well, 50% of them will respond to methotrexate, a cheap, old drug that we used to use for cancer.
Yeah, still do use for cancer.
Yes.
Yes. It's been around since the late 60s, more or less. Inexpensive, well-tolerated oral medication that is our gold standard. We start all patients on pretty much methotrexate unless there's some reason why we shouldn't. And based on their response, usually in a perfect world, within 3 to 4 months, we want that individual to be minimally active, meaning very few tender swollen joints, less than 30 minutes of morning stiffness,
that type
feeling
of
much more than self. And if they're not there, then we do this cocktail, start adding stuff, like the little medication cocktail, and we decide what's right to add or complement that.
And we can get back to this, but biologics are now the mainstay for therapy for many autoimmune diseases. So what's a biologic?
Yeah, biologics are antibodies. So the way I describe them is, if methotrexate is a rubber mallet, biologics are a bow and arrow to kill some. If you have a pile of ants and you want to mush them, methotrexate is just smushing stuff. Right. And biologic is much more precise.
Tiny little bow and arrow on each end.
Yep, it's very precise. And it is designing an antibody that attacks this signal, this inflammatory signal that's been secreted from cells in your body that tells, hey, white cells, come over here, attack my joints. So we're gonna block that signal with this antibody. So since you don't make it, we're gonna give it to you. And since it's big and it's a protein, you can't eat it, you can't swallow it, you can't absorb it. So we give it as a shot or an infusion.
Okay.
And then they just dissipate in your body over time. So they aren't metabolized by your liver or your kidneys, so they don't interact with other medications. Most people have no significant side effect from the med itself in terms of like lab abnormalities, etc. Where you get the shot might get red or swollen occasionally, but most of that we can work through. Yeah, but that's kind of the mechanism of a biologic. It's a mimic of what we wish your immune system would do.
Yeah.
We created that.
Right. So the only major side effect I see of those is a walletectomy.
There's that.
It's very expensive.
Right, and they, like all the medicines we give in rheumatology, they suppress your immune system, right? I always say, we're just turning down the volume on your immune system. It's behaving badly. We're gonna kind of squash it for a while, and then we're gonna hope that it kind of starts to settle itself or reset itself. So we can't say just suppress this inflammatory piece. We're doing it all over, so people are more at risk for infection when they take these medications. So they're not harmless, but they're pretty well tolerated, and under the circumstances, they're a good choice. But they're very expensive, yeah.
And they turn off your immune system, and sometimes we need that system.
Exactly.
So if I have a kind of a smoldering case of tuberculosis, for example, it'll explode, and then I'm dead from tuberculosis.
Yeah, and yes and no, in the sense that I think reactivation of tuberculosis is still fairly low risk even if you've been exposed, but yes, that enzyme or that molecule that we block makes a protective wall or covering in our lungs for that. So yes, you can unmask or reactivate some diseases. So we have to be very careful.
Yeah, pneumonia.
Hepatitis B, we have to worry about that.
Wow. Okay. So those are perfect. That's a perfect example. We can talk about more examples, and we're going to right now.
Yeah.
But I wanted to ask, a lot of people are buying certain dietary anti-inflammatory diets, anti-inflammatory supplements. We used to treat all of these with a lot of aspirin, Advil, Aleve, those kinds of things. What about those options of therapy besides the mallet methotrexate and the biologics?
Well, for the most part, if you have rheumatoid arthritis or psoriatic arthritis or systemic lupus that is involving your internal organs, there is really not a diet or over-the-counter supplement that is going to solve your problem. For the most part, this is a microscopic problem that at the level of your DNA, the cat is out of the bag, your immune system is sort of behaving badly. And we can't really shut that down with anti-inflammatories or turmeric or boswellia juice or these other items.
They can spend a lot of money on those things.
And they're not necessarily bad things. Like maybe you have some degenerative arthritis or just, stiffness or achiness. Those things may not be bad. But if you have a disease, it'd be like saying if you have diabetes, you wouldn't say, well, take an anti-inflammatory. You say, well, you need insulin, right? That is just a genetic need for an insulin-dependent diabetic. You kind of have to consider more aggressive therapy. And I wouldn't. Certainly people make those choices. You can bring a horse to water, but you can't make it drink.
Right. A person has a freedom to make their own choices.
And I support people in their decisions, of course.
But sometimes they make bad choices. Yes.
Well, and sometimes they say, okay, I get it now, and I want to go down this path. Some of it's just fear. They're just so afraid to take stuff. And usually we can, help them, educate them, make them more comfortable. But in time, usually things are going to get worse. And if you're really uncomfortable, you're going to say, I'm willing to take this risk. I need to feel better. And
the turmeric isn't doing it. Okay, now I'll go with the methotrexate.
And keep in mind, people with rheumatoid arthritis are increased risk of heart attack and stroke. That systemic inflammation is not just involving your joints. Even if you're tough and you say, I can tolerate it, it's not good for you to live in that state.
You have a coronary disease and vasculopathies and strokes earlier because of a chronic inflammatory process.
The similar risk to a diabetic patient. So going untreated is just not necessarily a very good idea in well-defined disease.
Right. Advanced age is what happens with diabetes, and that's just exactly what you're talking about. Don't let the inflammation go.
Right.
Come in and get it turned off.
Yeah.
And we have tools to do that now.
Right. And we generally recommend, ideally, in a perfect world, we'd see you very quickly. Of course, that doesn't happen. Our healthcare system is sort of challenged in that process. Access is a big issue. But the goal would be to be seen early and quickly. And can we put it in remission? We use the word remission with rheumatoid
Just
arthritis.
Like cancer.
And we can put it in remission, and we talk about taking people off of medication because these biologics, as we discussed earlier, are so effective that it's really changed the course of these diseases, to be honest with you.
So what are some of the biologics that we have?
Probably the ones that people are most familiar with are Enbrel, right? Phil Mickelson takes Enbrel for his psoriatic arthritis.
Yes.
Humira, they've been around the longest. Remicade was the first, actually, it's an infusion, but in terms of the shots you give yourselves. But then that's what we call anti-TNF, so tumor necrosis factor, that signal, that class. But there's a whole bunch of others. There's tocilizumab or Actemra, which inhibits interleukin-6. There's interleukin-17 inhibitors. There's rituximab, which eliminates B cells. It's very effective for vasculitis, and we use it in lupus, and we call it vitamin R. It's just good for a lot of rheumatologic diseases.
Wow. But it increased cost.
Yes, all these medicines are expensive, and it's a real challenge. How are we going to move forward as more and more of these medicines become available and more people need them? How are we going to afford to get these medications to everybody?
Fortunately, everybody does. Everyone does not need those kinds of illnesses those kinds of treatments because they don't have it, rheumatoid arthritis. These are relatively uncommon diseases, thank goodness. And half of them, or many of them, are treated by the old cheap methotrexate kind of thing. Right.
Some people will respond great to that, and we still we use our cheap oral medications as much as possible. And sometimes we can back off. We give you a biologic for a period of time, and then we can back off. Not to completely change your course, but like Prolia is a biologic that we use for osteoporosis.
Yes.
Now that's an incredibly common problem. So as we move forward, this class of drug is moving into more and more common problems, which then just compounds the challenges that we have.
I would much rather people exercise regularly to strengthen their bones than to have to take Prolia.
Yeah, in a perfect world, that'd be exactly. Manage your skeleton early.
Yes, that's right. It. And what is the most important thing that you can do to make your bones strong, and that is to use your bones.
Be active, absolutely.
Be active. So let's talk about different kinds of rheumatologic illnesses. We did talk about rheumatoid arthritis, and we've talked about treatments because all these treatments that we use for all these other conditions work with the rheumatoid picture. So others are, let's talk about other rheumatologic diseases. Lupus is one. And let's start with lupus, but you give me a run through of kinds of.
So lupus would be in the category of connective tissue disease, and that's an umbrella term for a lot of things that are kind of lupus-like. So you got your scleroderma, your Sjogren's syndrome, your mixed connective tissue disease, diseases that we call myopathies or muscle diseases, inflammation of the muscles that people just sort of have insidious weakness and rash.
Like polymyalgia, polymyositis.
Yes, and dermatomyositis. So so it depends on if you have lung or skin involvement, but that would be kind of under that umbrella of connective tissue disease. And then we have kind of another class of diseases that we call vasculitis. So that's going to be things like giant cell arteritis, which is a large vessel vasculitis, kind of common in older people, very similar or kind of a kissing cousin to polymyalgia rheumatica.
Right.
Then there's like granulomatous polyangiitis that used to be called Wagner's granulomatosis. Microscopic polyangiitis, there's just a variety of these vasculitis syndromes that can involve your lungs and your kidneys, and almost everyone has rash. Sometimes joint swelling comes and goes. So that is probably inflammatory arthritis, connective tissue disease, vasculitis are probably like a big chunk of what we see in rheumatology.
Let's take probably the most common of all of those diseases that we've discussed, and not degenerative joint disease or osteoarthritis, but polymyalgia rheumatica.
Yeah.
And I've seen a ton of in my lifetime, particularly because I'm a geriatrician. I care for the elderly. And so tell me about polymyalgia rheumatica, or PMR.
Yeah, that's a fun thing to take care of, actually, because it's the rare, not the rare, but it's one of the uncommon times that people hug you after they see you.
Yes, I love this one.
It's a good one. So people will have, usually people over 55, 60, proximal muscle pains, shoulders, hips, and it can be intense. I mean, people, and if they think back, they've been feeling kind of lousy, maybe they've been losing weight, just something's not right. Sometimes these people go to the emergency room. I mean, they just think they're dying. It's so painful. They can't get their arms above the head, can't do your hair. And you go in.
It's like the shoulder girdle and the pelvic girdle, right?
Shoulders and hips.
Trouble getting upstairs.
Exactly. Difficulty getting up off the toilet or climbing stairs or raising your arms above your head. Lots of stiffness, profound stiffness. And they go to the doctor because they're miserable, and the doctor will kind of recognize what they're saying and check a blood test that looks for inflammation, just a non-specific inflammatory blood test, and it'll be pretty high.
A SED rate is
SED rate, typically.
The ESR or the plain old SED rate. So get a SED rate. You can ask your doctor for a SED rate because you've got this pelvic girdle, shoulder girdle.
Yeah.
And the SED rate is what? What is it?
Maybe it's like 65 or 70, usually ideally less than 100. It gets much higher than 100, then we start to think about giant cell arteritis, which is kind of they're hard to tell apart sometimes.
Right. So, and I can measure a SED rate if I put blood in a tube and I watch how fast it settles, right? You explain that.
Well, that's exactly right. So the more protein that is on the red blood cell, the slower it's going to fall. And so the more inflamed you are, the more protein you have on the cell. And so it takes, it's the time at which that red blood cell settles in a tube.
And it takes longer if there's inflammation.
Yes.
That protein. So that's very interesting. So I've got this terrible pain getting up off the toilet, and I'm just ache all over, and I'm 80 years of age. And it's come on in the last 3 to 6 months, and I'm miserable.
Yes.
And I come into you, and you say, well, might be polymyalgia rheumatica. And so I'm going to check a SED rate. SED rate's 60. And it probably is polymyalgia rheumatica. So what are you going to do, Jennifer?
I usually give them a little bit of prednisone. You don't want to give too much. It's like Goldilocks. You don't want to give too much, and you don't want to give too little. But the classic is you give maybe 10 or 15 milligrams of prednisone, and within 24 hours, it's like a hot knife through butter. They are reborn their pain is almost gone, and they are the happiest people in the entire world.
And they come in and they
hug you. Yeah.
They hug you.
Yeah. Usually I'll check lab, I'll start some prednisone, I'll say let's come back in a couple weeks, and come back and they're like, oh, I feel amazing, and then becomes the long, slow steroid taper.
Right. Now I generally tried 5 milligrams to start with, and when they get a lot better with 5, I really try to not go that 10 or 15, but you sometimes have to, don't you?
Yeah, I've done it all different ways, and what has kind of been most effective for me is to do a good solid 15, and then I treat it until it's normal, the inflammatory markers are normal, and then we pull back, and I'll pull back a little quicker to get below 10. Some of that is, I don't know, maybe a lot of my patients drive a long way. Like if I bring you back and they're not that much better, then I'm like, did I give you enough?
Yeah.
So but there's no right or wrong. I mean, that's a good strategy as well. I mean, the least amount of steroids you have to take, the better in the long run. If so that's the goal.
Yeah.
So it kind of just depends. How miserable were they? Usually, probably by the time people get to me, it wasn't working.
Yeah.
Their doctor said I can't get them off the prednisone, or there's a variety of.
Right.
So I might see the more stubborn ones.
Yeah. Do people sometimes look like polymyalgia rheumatica and actually have lupus or rheumatoid arthritis or something else?
Typically, polymyalgia rheumatica will be a precursor to rheumatoid arthritis. So if I see somebody, so say you're 65 years old, you come in with classic PMR, and maybe you have a little bit joint swelling. Like I get a little sense of joint swelling on exam, but you respond great. As we come off that prednisone and you flare up, like they say, oh, now my hands are stiff again, or then I'll say, you actually have inflammatory arthritis. It was just sort of a precursor, a trick, and then I use methotrexate in those individuals because we're not going to be able to come off the prednisone without it.
And you don't want to stick a person in on prednisone higher than 5 milligrams for long periods of time? Or?
Ideally, correct. Yeah, I mean anything more than 10, I think is not a good plan. 5 or less would be preferable. So, if I have an individual, and I've had many who are, say they're 90 years old and they take 2 milligrams of prednisone a day, and they say, when I cut back below this, I'm just miserable. I might say, all right, 2 milligrams of prednisone, low risk, inexpensive, we're just going to let that go. If you say, well, I need 10 milligrams to function, that's a different story. We got to come up with a different plan. That's just not a good long-term solution.
10 is bad. So you mentioned doing testing in polymyalgia rheumatica. One thing that a partner of yours in the past, Jim Engelbrecht, who has been on our board too, and who's a dear friend and has been on our show quite a few times, he said to me, the rheumatology is one of those fields where you have backup lab, but for the most part, lab's not what's important. It's the clinical knowledge of the doctor. Take that comment.
I think that's really true. I always tell patients all of our diseases are clinical diagnoses. Usually by the time I'm done examining you, I've determined what you have. And lab is really either to reinforce what I'm thinking or to look for evidence of disease activity in other organs like the kidneys or whatnot, or to sort of determine a level of disease activity that I can monitor going forward. Is it getting better? Is it changing? But most of the time we can tell on exam what you have.
Yeah, you really wouldn't need all these lab things for rheumatoid arthritis. I mean, lab's important for some things, in particular, the SED rate for polymyalgia rheumatica, but it's, for the most part, it's a clinical world.
It really is. It's we rely a lot on physical exam findings.
And history.
Yes.
And have you, in your mind, thought that we have done too much on dependence on lab and not enough on the classic old history and physical exam?
Yes, and I think some of that has to do with the pressure to get people seen quickly, that we've kind of then default to, I'll check these things, and then we respond to the lab result, not to our clinical intuition.
And patients push for it. They want the blood test to prove that you're a good doctor and you're
They like
checking.
data, just like we do. We like data.
So, and one quick question about physical therapy in treatment for all kinds of arthritis. How important do you think that is?
I think physical therapy is fantastic, and I think it's been underappreciated. Patients see it as exercise. Like they say, oh, I'm busy, I'm very active. And good physical therapy has nothing to do with that. It's really helping you develop a program that you can maintain at home. So for rheumatoid arthritis, it might be seeing a hand therapist for joint protection principles and ways that you don't irritate your joints. Certainly for our core, I mean, I always say all of us in America don't have a strong enough core. You know, we just have those 4 vertebrae holding our top to our bottom, and we're all soft in the middle. And then we have back pain, and we wonder why. Yeah. So learning how to do that is important, and then continuing it. And when you get the right therapist for the right thing, it can work wonders.
All right. Well, there are many causes for chronic pain. Often physical therapy helps.
When it comes to autoimmune disorders, the number one disorder that we deal with in physical therapy has to be rheumatoid arthritis. There's many of them that we deal with, ranging from myositis to others, but rheumatoid arthritis is probably our number one disorder we deal with. You know, and what we see in the difference with osteoarthritis, you got to think of osteoarthritis as more of the wear and tear arthritis. And subsequently, the biggest difference is lifestyle choices a person may make will lead to more osteoarthritis. For example, obesity, and it causes a lot of wear and tear in the knee joints, and that's the osteoarthritis type problem. Even if you are taking a medicine, if you're not taking care of yourself, you're going to wear out that joint. So in terms of shoulders and upper body, as people get older, we're seeing this condition called adhesive capsulitis, and we call that frozen shoulder. Prevention often comes with 2 aspects. One, watching what you're doing. For example, if you are getting ready for the big cleanup in the spring and you decide to trim down every single bush in your yard and you haven't been moving and keeping in shape and strong, you have a high chance of getting hurt and injured if you're doing something you don't normally ever do. Inflammation, pain can lead toward things like frozen shoulder. And again, hinted on this, keep moving. Prevention by keeping active and exercising, especially with some type of strength training that does not cause increased pain or inflammation, is crucial to help with that prevention. Inside the house is a great place, great opportunity for people to keep moving. For example, maybe you're in the kitchen, standing at the kitchen table or the counter, holding on to that for balance, and start practicing just standing on one leg. Balance is very important. And we think of strength and movement, but balance can be something a person can improve on with practice. You got to practice at it. And then stairs are also a great piece of equipment. Sometimes people walk up and down stairs. Sometimes I have a person just use the first step, hold on to the hand railing, just go up and down on the step. As a physical therapist, we look at function. If your pain is affecting your function, that's a great time to go see your doctor. For example, let's say I want to get my shirt on, I have a hard time getting dressed, or maybe someone has a hard time hooking their bra, they can't reach around to hook the bra. That's affecting their function. If that pain is affecting their function, I highly recommend they go see their physician.
Thank you, Chuck. He's been on our show a million times, and we so much appreciate him. Physical therapy, I mean, that really is an important aspect of recovery and continuing function, wouldn't you say?
Absolutely. It's a wonderful complement to things that you're doing for your whole health picture.
Particularly with chronic pain. You know, you talk about people who are disabled with chronic pain. I think the most important thing we can do for them is to keep them going. The more they sit, the less they do, the more they hurt. I mean, I think about people who have fibromyalgia. Explain fibromyalgia to me.
Yeah, fibromyalgia is a very frustrating, widespread chronic pain disorder. It's not a disease like what we've been talking about, like a well-defined autoimmune disease or inflammatory condition. It's people who have pain, front, back, left, right, top, bottom, 24 hours a day, 7 days a week, unaffected by activity. And when we check them, we do their lab work and we examine them, everything's fine, except maybe they're just really tender, like even just to light touch, they're really tender. That's sort of the pathognomonic quality of fibromyalgia. But essentially, it's widespread chronic pain. And we don't know why people get it. we're terrible at treating it, and people suffer a lot with it. And so it's a very frustrating thing to have. People who have it are just frustrated.
You know, I think about it, and Joni and I were talking about this this week about people who have polymyalgia or have this chronic fibromyalgia pain. And she said, what do you think could be the cause? And I'm stomping around on my feet because I have peripheral neuropathy associated with the chemotherapy I'm getting. It also took my hair. And that's painful. It's always there. And I wonder if they don't have some form of a degenerative neuropathy of some kind.
Yeah, it's definitely a central nervous system problem. It's a communication and signal problem.
A signal problem.
Yeah, you can biopsy all those tissues and you will see nothing abnormal in their muscles or their joints or their bones.
And their lab, I think when people have peripheral neuropathy, I check their thyroid and their B12 level, and I put them on B12, and now I'm putting them on B1, you know, thiamine, because the similarity to the neuropathy is associated with alcohol excess and the thiamine deficiency that people with alcohol commonly have. So it won't hurt.
Right.
But probably the most important thing is physical therapy or activity.
And exercise, yeah.
Exercise.
Yeah. I mean, we have gone round and round with medications and different treatments for people with fibromyalgia. And I usually describe it as like a circle. So the worse you sleep, the worse you feel. The worse you feel, the less you do. The less you do, the more you hurt. The more you hurt, the worse you sleep. The worse you sleep, the worse you feel. And it's this vicious circle.
Worse,
and you have to start putting little barriers within that circle. So you have to get quality rest. That's the number one important thing.
You don't want to use the benzodiazepines for sleep, because that's an addictive,
You don't want to use
terrible.
any addictive habit-forming medication with fibromyalgia because the pain's not going away.
No.
We're going to mitigate it. We're going to manage it as
Live
best
with
as
it.
possible, but it's not going
Function.
away. So it's not good to pick anything that you have to titrate, or that's going to become habit-forming.
Right. So no prednisone, no steroids, and you try to avoid and no benzodiazepine
Right.
like Valium or
Right.
Ativan or
And no Ambien.
no Ambien. No, avoid Ambien like
Yep.
the plague on this
Yep.
one.
No tramadol. Ideally, no tramadol, no narcotics, because they're not.
Helping.
Well, I mean, I would argue they maybe help a little bit because they do blunt the central nervous system. So people might find they're helpful, but the consequences of narcotics are just not worth it, because it's like a bottomless pit. Say you have 10 out of 10 pain and I put you on something, then you're like, oh my gosh, that really helped a lot. Thank you, Dr. May. Then a little bit later, come back and you're like, I'm back to 10 out of 10. Because it's almost like the body forgets that it felt worse. And now this is my new lowest day. And so you just keep titrating doses, and people get on really high doses of medicines that tend to have a side effect of making them sleepy or have weight gain. And these are all things you're battling anyway. They already feel lethargic and don't have a lot of energy. So medicines like gabapentin or Neurontin is a good
Those are
choice.
anesthesia drugs, and they have, if you're going to use a medicine, anesthesia drug. Gabapentin is a good one.
Yep, they help kind of blunt that central nervous system response. And then things like duloxetine or Cymbalta, which are medicines that elevate norepinephrine or serotonin. These are chemicals in your brain, and we know when we elevate them, the pain is less intense, less severe.
They're commonly used for depression. And I think all of the antidepressant drugs, the SSRIs, you know, the fluoxetine and sertraline and those kinds of things. And you agree?
Yeah, but it's specifically the Cymbaltas that elevate both the norepinephrine and serotonin are actually indicated, you know, for fibromyalgia, and they've even shown some data for people with osteoarthritis.
And they're not that expensive. You can, they
should be affordable. They're generic, and again, you might try them and find them not helpful, but for the most part, the goal is, instead of having these really highs and really lows, you have more evens, less days in bed, less days where you didn't go do anything, you know, and you're really down. These people can be down for days.
Yeah. I wonder, often I think people talk about depression as a cause of fibromyalgia, but I don't think that's true. I think there's more to it, of course, than that.
Yeah, and I mean, fibromyalgia, that's the term. It's, again, not just one thing that causes it. So there are some people who have just kind of mildish symptoms that respond really well to some of the therapies, and they do pretty good. And other people, it doesn't matter what you give them. I mean, they're just miserable. And there's all kinds of background stuff. Maybe people who've had trauma have a higher incidence of developing these kind of chronic pain syndromes. So sometimes counseling, psychology, just, you know, starting developing coping skills, all these things complement. So quality rest, exercise, which has been found to be better than any pill that we give for fibromyalgia, is exercise, which is the last thing they feel like doing because they're miserable, but activity. And then counseling, coping strategies. Those three pieces are really what we have.
So I love what you say about exercise. And I like to say to people, walk away from your house 6 blocks and then walk home again. That's 12 blocks. That's 1 mile. You do that every single day. That's the number one baseline. The second thing was a counselor of some kind to encourage you, maybe an antidepressant to go along with that counseling. And then the third thing was what? I forgot. You said 3 things.
Quality rest.
So, and how do you encourage that? There are some quality rest meds that are not benzos. Do you use any of those?
Well, I use gabapentin in the evening because the side effect is it makes people a little bit sleepy. So I'll try that in the evening, and then we review sleep hygiene, right? You know, avoid stimulants after 5 p.m. Don't nap. You know. Yeah, don't have any television or screens in your room. No television
in your room.
Yeah. So make your room for sleeping. You know, we review sleep hygiene.
If you wake up, go to another room, do your reading of the dictionary or something boring, and then go back to
When
bed.
you feel sleepy, try again. If you don't fall asleep in 10 minutes or so, do it again. Kind of retrain your body to sleep when it's supposed to sleep and be up when it's supposed to be up. But then I use gabapentin in the evening, or depending on kind of how bad somebody feels, amitriptyline, you mentioned, a little bit of amitriptyline or cyclobenzaprine. These are also old-fashioned antidepressants that elevate norepinephrine, and again, they make people a little bit sleepy, and it seems like you take those in the evening, you might get a better rest, and hopefully not a lot of daytime drowsiness, and that seems to kind of help push people through. So sometimes I'll titrate that evening dose of gabapentin.
I really like amitriptyline. I used to use a little bit of Triavil at that case, which carried a certain amount of, it had 2 tranquilizers, well, a tranquilizer and the antidepressant in it, and it did give people some sleep. But you know what? They're not making that drug hardly anymore. It's so
well, now
old.
The challenge is they don't like older people to be getting any amitriptyline. So
yes, that's the, and I think that's a wrong choice.
Yeah, so we have to deal with that. Yeah.
So it's on the list of don't give, but they don't have Ambien in that list, and they don't have. I mean, they have things that they should not be putting on that list, and they have things that aren't on the list that should.
Yeah, and I think amitriptyline in high doses, which I don't know anybody who gives it in high doses anymore, that would be appropriate.
150, 300 are a little high.
Yeah, and the little
10.
5 to 10 at night is not going to cause you problems.
No.
But yeah, that's sort of a challenge that we've run into.
You know, one of the major treatments for chronic pain has been for people to take nonsteroidal anti-inflammatories or to take acetaminophen or Tylenol. And it's no wonder that they put acetaminophen in with hydrocodone and oxycodone, because it's a better pain medicine than the narcotics, except for times when there's a blockage of the smooth muscle tube. Then the narcotics really work, like kidney stone, gallbladder disease, obstruction of the colon, you know, those kinds of things. On the other hand, it's a temporizing thing, and so I really think that nonsteroidals are a good choice, except they can hurt the kidney, and they may burn holes in your stomach, and there's some new data.
Well, yes. I mean, I don't know that it's necessarily new, but it sort of continues to support that all anti-inflammatories, not just Vioxx, I don't even remember Vioxx back in the day, can potentially increase your risk for cardiovascular events. And in a perfect world, you might say nobody should take them. But in the real world, they're ubiquitous. People buy them over the counter and use them probably in inappropriate doses regularly. So I think you have to just consider the patient's cardiovascular risk and how much anti-inflammatory you're giving them, and is it safe to take that. And I always say with any of the anti-inflammatories, they're really treating a symptom. They're not really preventing disease progression or changing the outcome. So if you take your Celebrex or your diclofenac or atodolac or whatever your
all
doctor...
of those are non-steroidal anti-inflammatories.
Yes, all those, and there's
They're like
hundreds of
aspirin
them.
or Advil or Relief.
Right. And if you take it and you're like, I don't know that I notice anything, then don't take it. There's no benefit to taking it without a clinical response.
Yeah, I have heard that Toradol or the ketorolac is a real lifesaver for people who have things like migraine headache episodes or severe episodes of severe pain. And I know my dad came home with a cancer dying process. We got him home. We took him from the hospital home to the lake cabin for his last hurrah. And Toradol shots got him through it, and so we were pleased about that. But so it's effective, but I don't think all the time. I think episodic use of the nonsteroidals is the way to go.
Yeah, it's challenging because some of our diseases, which we didn't get into, but for example, ankylosing spondylitis, which is basically an inflammatory condition of your back and your SI joints or your butt joints, that really responds to anti-inflammatories, and people will have to take a pretty decent dose consistently. Usually they're younger people, which they tolerate those medicines a little better. So sometimes we give them, or kids with juvenile inflammatory arthritis, we give high doses of anti-inflammatories long term in those conditions, and that is really disease modifying, but that's uncommon. For most people, you're taking it for knee pain or tendonitis, and I'll say, take it for a couple weeks at one dose and then try to pull it back and see what's the lowest dose, and you might find that just taking it here and there works just as well. And the less you take, the better.
So let's talk about back pain. We have a little bit of time left. Like 5 minutes left. Back pain is one of those things that people struggle with. And it's probably the most common reason why people miss work. And it's because our core is not strong enough. So the most important thing is to do sit-ups and push-ups and walk regularly, right? And that's what we should all do, but we don't all do that. And then we go out and shovel the walk when we haven't done one darn bit of exercise the whole summer, and then you come out and you shovel the walk and you end up with back pain. Duh. What's your take on that? How do you handle that? And people sometimes go to surgery when there are experts who say they shouldn't be going to surgery.
Well, so my approach to back pain is a little bit different, because when I hear somebody about back pain, my first instinct is this inflammatory back pain or non-inflammatory back pain?
Okay.
So inflammatory back pain is pain that wakes you up at night, that's better with activity, as opposed to mechanical back pain, like you do stuff, it starts to hurt, you got to sit and rest and recover. So if you're under 50 and you're having kind of inflammatory back pain, now I'm thinking disease, I'm thinking a totally different treatment plan.
So say that again. A young person, back pain wakes them up at night, gets better with activity.
Better with activity.
Different story.
Totally different story.
Go to your doctor.
Yeah.
Inflammatory back pain, ankylosing spondylitis.
Or like kind of pain in the SI joint, right in kind of the butt cheeks. That is, and maybe you're like 15 and you've always had it. They just kind of are used to it. And then you'll say, well, that's not normal. And they'll say, really? Doesn't everybody have that? You're like, no. No. Not everybody. So it's kind of something people have had for a long time. They're kind of used to it. But
the other kind,
mechanical back pain is different. And so for me, that's, exactly what you talked about. It might be use of an anti-inflammatory. I might include a muscle relaxer, like a low dose of that cyclobenzaprine that we talked about. Heat, if it's a muscle spasm, but only 20 minutes of heat or the muscle gets kind of irritated, with stretching, physical therapy, and I'll usually recommend at least 6 weeks of physical therapy. And if you're having any shooting pain, we call radicular pain, where the nerves irritated, like if you had a disc that bulged and you have pain shooting down your leg.
You can feel the nerve going down the leg.
It'll shoot.
You call that radicular. That's not ridiculous.
Yeah.
It's radicular.
Yeah. But if that's happening, but again, usually you give it 6 weeks of conservative care, and most of the time it gets better. If it doesn't, that's when you're kind of more into maybe you have to do some imaging. Maybe you need to see a physiatrist or a physical medicine rehabilitation doctor. Maybe
an injection of a steroid.
Maybe you need to have an injection or a different physical therapy program that's more well defined for your problem if the basic sort of physical therapy program wasn't working. Again, the right physical therapy for the right problem will make all the difference. And sometimes when you write back pain to the PT person, they might start a program that isn't quite the right one. When a physiatrist sees them,
that's an MD that has been trained to be a rehabilitative
right, and they might say, oh, you need this exact physical therapy technique, and they can even better zero in when we're not having success.
Right. If I start losing the dorsiflexion of my foot, or the plantar foot, I can't push off, or I can't lift up, it drags and I keep catching. I'm losing a nerve. That's radiculopathy. That's radicular pain.
Or, weakness.
And that's a nerve that's being squeezed. When you have that weakness, does that mean I need to get in?
Yeah, definitely. Certainly, what I tell people, nothing should get worse. You shouldn't be getting anything worse. No weakness, no bowel or bladder incontinence or numbness. Anything like that is really more of a, you need to be seen, and we need to do some more detailed imaging and figure out what's going on there.
All right. We've got 1 minute. I thought maybe I'd let you summarize what you think people should take from today's show.
I hope people take that rheumatology is a subspecialty that focuses on autoimmune disease and ways to sort of address your immune system or redirect your immune system to make you feel better. And that there's lots of unusual signs and symptoms that go with those diseases, but that there's lots of good treatments. I always say we don't cure things, but we can manage things. And so we have lots of good therapies that are effective and can help manage and control disease that allow people to have a high quality of life and function. We have much less or almost very little people becoming disabled from our diseases compared to the past.
Wonderful information, and I think very helpful for people. And now for the answer to tonight's Prairie Doc quiz question. Pain management should take into consideration A, the importance of sleep, B, pharmacological effects that may not always be effective, C, physical rehabilitation that helps bring people to a return to function, or D, all of the above. And the answer, Jennifer May, is?
All of the above.
All of the above. D, all of the options can affect pain. We'll be right back after this.
For more than 16 years, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Prairie Doc physicians and health professionals continue to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
For years, I cared for a lovely woman with scleroderma. It all started with Raynaud's phenomenon, when her fingers became pale white and then blue and red and painful whenever her fingers got cold. Raynaud's phenomenon occurs in about 4% of the population, usually associated with no other condition, but sometimes along with rheumatoid arthritis, lupus, or, in this case, scleroderma. Our patient also experienced progressively tight and shiny skin over hands, and then chest, and then everywhere. She had tiny red spider vein spots, heartburn, weight loss, weakness, and puffy joints. Through the years, her fingers became scarred and quite immobile, with always worsening sores on the tips. Through it all, this wonderful lady had a very positive attitude and always seemed to have a smile on her face. Although, near the end, the skin of her face became so tight that smiling was a challenge. Yearly, about 3 out of 100,000 middle-aged adults develop scleroderma. When full-blown, it's called systemic sclerosis. This very puzzling autoimmune condition often demands a lot of symptomatic medical help, even though at this time we can't stop it. Normally, after a cut or a sore develops, and in order to heal the wound, our bodies trigger both the immune system to fight off invasion of bacteria, fungi, and viruses, and special tissue repair cells to close off the wound with collagen and connective tissue. Once healing has happened, the collagen making usually stops, but not with scleroderma, where, for some unknown reason, scarring continues uncontrolled. We think that inheritance, hormones, certain infections, and long-term exposure to pesticides, silica dust, or polyvinyl chloride all might have something to do with the cause, but we really don't know. We also don't know why 4 times as many women get it than men, that sometimes it involves just a spot or a sword-shaped skin area and never progresses, that sometimes it comes with Raynaud's phenomenon, involvement of the esophagus and parts of the skin, but doesn't progress, and that in some unfortunate cases, it progresses everywhere, like in my patient. Similar to many other autoimmune conditions, scleroderma is one where the immune system, for some undefined reason, runs amok, mistaking normal tissue as a foreign invader. Scientists, industry, and physicians are on a hunt to learn first why scleroderma happens, and then how to stop the process while allowing normal healing. If we understood more about scleroderma, we would find it easier to smile. Well, a big thank you to our guest, Dr. Jennifer May. Her experience in this area brought great insight to our discussion today. Thank you so much, Jennifer.
My pleasure.
And a big thank you as well to the South Dakota Public Broadcasting crew who have helped with our programs in Rapid City. Their hospitality here made our time feel like home. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
We rely on our hearts working 24 hours every day. If something interferes with that, it's a bad thing. Rhythm problems and sudden death. Next time, On Call with the Prairie Doc.
Useful, scientific-based medical information delivered in a respectful and compassionate manner. This is what we get from the Prairie Docs. I am proud to serve on the board of the Healing Words Foundation. Our nonprofit organization works behind the scenes building financial support to continue and expand Prairie Doc programs. We thank the many health providers who volunteer their time to answer our health questions. Significant funding is required to produce and distribute video, radio, and print throughout the region. Your donations will help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. I grew up with Rick Holm on the prairies in DeSmet. On behalf of the Healing Words Foundation,
And on behalf of a lifelong friend,
we invite you to join our mission. Go to prairiedoc.org and click the donate button today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians, Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic, Aberdeen District Medical Society, 3rd District Medical Society, 7th District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.